Welcome to our webinar titled Advances in Treating High-Risk MDS and AML. Thank you for joining us. My name is Lee Clark, patient educator, and I'll be moderating the presentation today. As we get started, we recognize the generous support of Bristol Myers Squibb, Jazz Pharmaceuticals, Agios, Genentech, and Takeda Oncology, and the generous support of our patients, families, and caregivers for supporting the webinar program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the webinar. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type in your question or comment in the small text box window, and when you have finished typing, just hit enter. We will do our best to get to all questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming question. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Dr. Alice Mims, who is an associate professor of hematology at The Ohio State University Comprehensive Cancer Center, the James. She received her medical degree and Master of Science in Clinical Research from the Medical University of South Carolina, and then completed a combined fellowship in medical oncology translational research at Ohio State University. With that said, it is my pleasure to welcome Dr. Mims.
Hi, everyone. Thank you so much for the opportunity to be here to talk with you today. I will say it's really an exciting time for both MDS and AML, as there have been multiple new therapies that are either recently approved or on the forefront. And so we're really excited to have new opportunities to offer to patients. So specifically what I wanted to talk about today, as mentioned, are high-risk MDS and AML. And so I wanted to take some time to define what we classify as high-risk disease for both of those entities. And then next to talk about current approaches of treatment for MDS and AML patients for these high-risk features, more specifically for subgroups including intermediate and high-risk MDS, secondary or therapy-related AML, FLT3 mutated AML, and older adult AML patients. Also, some ongoing and future research directions for other higher risk subtypes, including TP53 mutated disease, and again, studies in older AML. So for MDS, this is really a heterogeneous group of malignant hematopoietic stem cell disorders characterized by clonal hematopoiesis. And patients really develop symptoms or issues that come about from having both quantitatively and qualitatively abnormal myeloid differentiation that essentially leads to cytopenias, meaning low white blood cell count, anemia, and low platelet counts. And so there's also immune dysregulation. And for MDS, there really can be a wide variety of how patients have in regards to outcomes and their risk of progression to acute myeloid leukemia. So back in 1997, so quite some time ago, a group of physicians who treated and researchers who treated MDS decided, well, can we somehow identify features that may help us predict how patients will do with MDS? And so we had something called the International Prognostic Scoring System, or IPSS, which was developed after evaluating about a little over 800 patients with MDS, but a caveat, it also included patients at this time with 20 to 30% blast, which at this day and age would be considered acute myeloid leukemia. But there were three variables that really seemed to go along with prognosis, which were the percent of bone marrow blasts on the bone marrow, with these different ranges listed here. With the higher the amount, the higher the score. Also looking at different cytogenetic abnormalities that were defined as either good, listed as normal, a -Y, a deletion 5q, deletion 20q, poor, which are complex, meaning 3 or greater cytogenetic abnormalities or an abnormal chromosome 7, or intermediate, which were all others. And then really just the number of cytopenias. So you had a higher score if you had 2 to 3 versus 1 of these being present. And so as you can see here, based off of the risk group, it ranged from low to high, and based off of having those features that I mentioned. And median survival seems to get worse the higher the risk, and the risk of transforming to an AML also increases with the higher risk score. Now, there are limitations to this prognostic scoring system because it didn't consider the severity of cytopenias, just if they were there or not. At that point in time, the cytogenetic abnormalities were more limited to what we have today, and not all patients were represented. It really was just designed to use at diagnosis. And so as people progressed in their disease, it wasn't as applicable to them to help predict how patients would do. Also, it excluded higher risk patients who had MDS, secondary MDS that developed from another bone marrow process, therapy-related MDS for patients who developed this from prior exposure to chemotherapy or radiation, and a subtype called chronic myelomonocytic leukemia. And then also they noted that there was quite a wide variety in outcomes for patients with lower risk disease, so it wasn't quite good at predicting outcomes for those lower risk patients. So back in 2012, they decided to revise this, looked at additional features, and as you can see here, for the cytogenetics, they added 2 additional groups as listed. There's now very good as well as very poor. The blast percentage have changed from less than 2% as a low risk, and then just greater than 10%. And again, those 20 to 30% are not included, as those would be classified as AML. Cytopenias were also now scored based off of their severity and not just if they are present or not. And then based off of this, as you can see, there are now 5 classifications that range from very low now to very high. And again, as you get closer to that very high, the median survival goes down quite exponentially, and the median time to, this represents 25% of patients in this group progressing to AML, it goes up as well, so the risk becomes quite high for these patients. And so to mention on a deeper level for molecular mutations, we are starting to do mutational analysis as a standard for MDS, but that's, at our center, other major centers are looking at that, but it's not part of routine evaluation. Sorry, I was muted for a second, but presence of certain mutations, as listed here, could convey higher risk prognostic features. These are not yet incorporated to any prognostication system. We hope that will be evolving over time to do so, but when we see these mutations present in our patients, then typically we tend to upgrade them. If you're intermediate risk, you may be considered a higher risk and approach a little bit differently. So currently for higher risk patients, so intermediate to higher risk, we think about early initiation of treatment with a class of agents called hypomethylating agents. And those are azacitidine or decitabine. I'll talk about a newer version of that in just a few minutes. But with these agents, we see complete remission rates of approximately 20%. These therapies are not considered curative, but they do seem to slow down the progression of AML. In a randomized trial comparing azacitidine to best supportive care, there were 20 months before transformation of AML for patients versus 13 months for best supportive care. And so we really think about that to try to decrease or to increase that time where that may happen. Really the only curative potential treatment right now for MDS is allogeneic transplant. And so for patients who we think may be candidates, we want to go ahead and screen and look for potential donors at time of diagnosis. And another potential important aspect to doing treatment with a hypomethylating agent is we know if we can get the blast percentage down to less than 5% with treatment prior to transplant, if they have a better response, then they have decreased rate of relapse after transplant. So transplant is really the third most common indication. For our MDS is the third most common indication for transplantation. And then looking at those scoring systems, there's a decision model we typically think about for newly diagnosed MDS, where for lower risk, very low, and then some intermediate risk, we wait until we see progression, because patients can live for quite some time and do well with good quality of life with this disease. And then transplant we really reserve for those with higher intermediate to high to very high risk patients, because we know that outcomes are going to be poor without trying to intervene earlier. If that again is the patients are candidates, and that is something that they think is, after hearing risk and benefits, they'd like to proceed with. So one exciting thing on the forefront for MDS is there was a recent FDA approval for the combination of decitabine with another drug called cedazuridine. And this is for previously treated and untreated newly diagnosed or secondary MDS or CMML with intermediate, based off of IPSS, intermediate 1, 2, or high-risk scores. And this is actually really exciting because it's an oral agent where the decitabine, which is a nucleoside metabolic inhibitor or hypomethylating agent, and cedazuridine is a cytidine deaminase inhibitor. And so how the addition of the cytidine deaminase inhibitor helps, because typically decitabine gets degraded in the GI tract if you give it by itself, because there are high levels of cytidine deaminase. And so that limited oral bioavailability. And so by adding this agent, it was able to increase the systemic exposure of decitabine. And so there was actually a phase 3 study that was actually a pretty cool design, where they randomized patients to start with either the oral combination or IV decitabine. But in the same patient, for the subsequent cycle, they would receive the alternate therapy. And in the same patient, they would look at drug levels. And they saw that there was similar systemic exposure with the oral combination to the IV medication. And so based off of this led to the FDA approval. And there's similar efficacy and safety profile as would expect with decitabine. And so this is given orally on days 1 through 5 of a 28-day cycle. And just speaking with patients and talking with them about this, they're very excited, because it limits or it decreases the time patients are in the clinic. They don't have to come for 5 days in a row to do the IV treatment. And so it gives them more time at home and I would say a better quality of life. So this is new, and we'll learn more as it's out in the community, but I think this is a great advance for the MDS community. Now moving on to AML. So AML is classified based off of morphology, looking for dysplasia, looking at certain surface or intercellular protein expression. Again, cytogenetics and genomic features such as gene mutations are also very important when looking at prognosis for this disease. And so this is a very busy slide, but this is something that we use when we're thinking about patients and how to proceed forward with treatment. And this is the European Leukemia Net that was just updated in 2017 that looks at genomic features with cytogenetics and molecular mutations to help predict how patients will do with standard therapies. And so for favorable patients, there's a potential to be cured with chemotherapy alone. And so many times we will reserve transplant unless they do not respond as expected or relapse because there's still a high chance to go back into remission. For intermediate and adverse risk, we more strongly think about transplant for patients who are able to get into remission. And so some specific subtypes that I mentioned that I'm going to be discussing are FLT3, ITD, this high allelic ratio, TP53 mutated, and then also I'm going to talk about a higher risk group that typically has complex karyotype or TP53 mutated with a therapy-related or secondary AML. And so these are groups of patients that have, less chance of going into remission as far as with TP53 or therapy-related with standard therapies. FLT3 ITD mutated can go into remission, but it can be difficult for patients to stay in remission. And these groups also have a high risk of relapse after transplant as well. And so ways to think about potentially mitigating that. Another risk factor that's very important is age. And so we know adult AML is a disease of older patients, and we define that with the cutoff of 60 or above being older, because patients with this, even if you have the same genomic features, seem to have worse outcomes for reasons we're still trying to better understand. But as you can see here, based off of cancer.gov data, that about for new cases, about 35% are less than 60, but have a 35 to 40% chance of being potentially cured, while those 60 and above, they're about 65% of patients are the majority, while 5 to 15% of older primary AML patients are potentially cured. So, and then looking at this in just a different way when we're talking about that ELN classification, so looking at younger patients and disease-free survival and overall survival, you can see that those with favorable features have reasonable outcomes, while they're still not as good as we would like them to be, while intermediate and adverse risk don't do as well. When we look at patients who are 60 years and above, you can see even though ELN favorable do better than ELN intermediate or adverse, they do much worse than younger patients. And the intermediate really is along the lines of adverse risk for older patients. And so you really want to strongly think about transplant for patients who are candidates. So age remains one of the most important prognostic factors in AML. So to move on to talk about treatment, so I like to highlight where we were even back in 2015 and just how far we've come with options. So we essentially had where we could give induction chemotherapy, so intensive chemotherapy for patients who were felt to be candidates and could tolerate it. And for patients who were not, we talked about less intensive treatments with hypomethylating agents like decitabine and azacitidine, low-dose cytarabine, which is more commonly used in Europe, it's less so in the US, and then supportive care or hospice, or clinical trials. And so for newly diagnosed patients, and I apologize if this is a little bit difficult to read, but you can see we have come quite a long way since approvals in 2017 with immunotherapy with the CD33 antibody gemtuzumab, the CPX351, which is a liposomal daunorubicin and cytarabine, which I'm going to talk about more. Adding a FLT3 inhibitor for FLT3 mutated AML to induction chemotherapy. We have an IDH inhibitor, and then a BCL2 inhibitor seems to improve outcomes when added to hypomethylating agents and low-dose cytarabine, and also a hedgehog inhibitor called glastigib to low-dose cytarabine. There are also more options in relapsed refractory AML. Again, FLT3 inhibitor with gilteritinib. There are two different IDH inhibitors, ivosidenib and enasidenib, and again, the CD33 antibody, gemtuzumab. So to talk about these specific high-risk subgroups that I mentioned, I first wanted to start off talking about secondary AML that arises typically from MDS or other myeloproliferative neoplasms or therapy-related AML. And so recently, in the past few years, the US FDA granted approval to this liposomal combination of daunorubicin and cytarabine for induction and consolidation for treatment of newly diagnosed adult AML with MDS-related changes or therapy-related AML. And so when we talk about 7+3 standardly, it's a combination of 3 days of an anthracycline, daunorubicin, or idarubicin with 7 days of cytarabine given concurrently. And so there was a design of a new formulation given in this liposomal complex, and as depicted here, with a 5-to-1 molar ratio of cytarabine with daunorubicin. And it's thought that by giving it in this method that there's a slower release of the medication, maybe some potential less side effects, and potential longer exposure to leukemic stem cells that could improve outcomes. So initially this was studied in older patients, 60 to 75 years, all comers. And there was not a difference when comparing to 7+3 with this agent. But they did a subgroup analysis and saw that patients with these higher risk features of secondary or therapy-related AML seemed to do better with this new formulation. And so they designed a second trial looking at randomization between the CPX351 to compare to 7+3 for these patients. The CPX351 is dosed on days 1, 3, and 5 for induction. And so what was seen, and I'll just highlight here, is that there was improved overall survival depicted by this blue line with the CPX351 compared to 7+3 for these patients. And then also interestingly, for patients who were able to go on to stem cell transplantation, the patients who had received CPX351 seemed to have better outcomes after transplant compared to those who received 7+3. Now, there's a lot of theoretical ideas about why this may be true, potentially longer exposure to the agent with a deeper remission going into transplant, but it's still not clear as to the exact mechanism of why this is being seen. FLT3 mutated AML, specifically ITD mutated AML, has higher risk features. We also talk about TKD or tyrosine kinase domain mutated AML, but that does not seem to have the poor prognostication of the ITD mutated disease. And so with FLT3, ITD or TKD, we can see that there is a really overdrive of this JAK-STAT pathway that leads to improved survival and proliferation of leukemic stem cells. And so by targeting this, we hope that we're turning that off. And so the first FLT3 inhibitor to target FLT3, both ITD and TKD, is midostaurin, and it was given in combination with 7+3 induction and consolidation for newly diagnosed mutated adult AML patients. And so this was the study design where essentially patients 18 to 60 years of age with FLT3 mutated disease were randomized to receive standard therapy with induction or consolidation, but either receive midostaurin or a placebo. And it was a double-blinded study. They also could receive maintenance afterward, but I'll mention a caveat about this. So when they looked at outcomes, though, for all the patients with the intention to treat analysis, they saw that survival was improved with adding midostaurin to the treatment compared to the placebo arm. As most patients ended up going to transplant, not many patients went on to receive the maintenance therapy. So the current label by the FDA is just to give it with induction and consolidation because they don't feel like there is enough evidence to show that it's helpful as a maintenance drug because there were so few patients actually who were available for analysis for that part. Also, even though this was studied just in patients 18 to 60, there is not an age cutoff in the label indication. And so we do treat patients older than age 60 with this combination therapy if they're induction candidates and have a FLT3 mutation. So midostaurin by itself, when it was looked in the relapse refractory setting, didn't really seem to have much single agent activity. And so that was a bit disappointing. But more recently, there's been another FLT3, second generation FLT3 inhibitor called gilteritinib, which has been approved for treatment of relapsed or refractory FLT3 mutated ITD or TKD adult AML. And so this was based off of results from the Admiral study, which was a phase 3 study, randomized trial, and they looked at 371 relapsed refractory FLT3 mutated AML, which most were ITD only mutated. A few had TKD and a very small amount had both mutations. And 2/3 were randomized to the gilteritinib, and 1/3 were randomized to standard salvage chemotherapy, which could be intensive or low intensity, which were pre-selected prior to the randomization. And the primary endpoints were overall survival and then complete remission with partial hematologic recovery. And so looking at the responses, you can see that the CR rates, even complete remission and those with kind of partial hematologic recovery were improved compared to the salvage chemotherapy arm. And if you look at the overall response, there was 67.6% with gilteritinib versus 25.8% with salvage chemotherapy. And so looking also at overall survival, you can see that there was an improvement with the gilteritinib compared to the salvage chemotherapy. However, again, this therapy is not considered curative. Most patients will go on to relapse at some point in time, but maybe a method to either bridge patients to get them to a response where they could go to transplant, or secondly, may at least give patients some time with a better quality of life, taking this as an oral pill, while having some response and decreased time in the clinic and not having to be in the hospital for intensive salvage treatments. So next I wanted to move on to talking about older patients and the newer exciting target of BCL2. So BCL2 is essentially an anti-apoptotic protein that binds these pro-apoptotic proteins, BAX and BIM, and when you add a BCL2 inhibitor called venetoclax, that allows these to dissociate and allows signaling to happen in the mitochondria of a cell to tell the cell to undergo apoptosis or to die. And so venetoclax has been studied with different combinations, but was granted continued approval with hypomethylating agents, both azacitidine and decitabine, for specifically treatment of newly diagnosed AML patients who are 75 years or older, or younger, 18 or older, who have comorbidities that would preclude the use of intensive induction chemotherapy. So this is the VIALE-A study that was recently published in the New England Journal of Medicine. that showed improved outcomes with adding venetoclax to azacitidine. So again, patients with those caveats, 75 years or older, or 18 to 74, who had at least one of the comorbidities listed, were randomized 2/3 to the venetoclax plus azacitidine and 1/3 to a placebo plus azacitidine. And they looked at the primary endpoint of overall survival. So looking at overall survival, you can see that the median was 14.7 months with adding the venetoclax to the azacitidine, and was 9.6 months with the azacitidine plus placebo arm. One other thing to note is that the complete remission rates were much higher with adding the venetoclax versus the placebo. Now, complete remission rates are depicted in the green here, which were 36.7% versus 17.9% with the placebo azacitidine group. And then when you added on complete remission with incomplete count recovery, so less than 5% blast, but the counts hadn't fully recovered, you had an additional almost 30% of patients versus 10% with the azacitidine placebo group. One other nice thing about this treatment is the time to getting into response seems to be shorter. So when typically for azacitidine, decitabine, we estimate 3 to 4 months, this seems to be 1 to 2 months. And so that means, you know, a response, hopeful improvement of counts, that leads to less frequent office visits, improved quality of life with this therapy. There's also a contingent approval of venetoclax to low-dose cytarabine for these same arms. And so this was a study, a phase 1/2 study using venetoclax with low-dose cytarabine in patients 60 years or older with untreated AML who are ineligible for standard treatment. This is the ramp up, which I guess is a little bit different than the venetoclax. It goes up to 600 milligrams, while venetoclax goes up to 400 milligrams in combination with hypomethylating agent, with some dose adjustments for either of these combinations based off of other drugs like antifungals may cause changes to the dose of the venetoclax. But this is given with low-dose cytarabine subcutaneously on days 1 through 10. And compared to what we would expect with low-dose cytarabine alone, looking at CR rates that were about 54%, median time to first response was about 1.4 months, the time to best response was 2.8 months. And this is much better than what we would expect with low-dose cytarabine alone. And so that's what led to the contingent approval. There was a phase 3 study looking at comparing outcomes, and we're waiting to hear kind of if this will fully get full approval or not. And so we're waiting to hear about this. This also just shows, which I think would be expected, the deeper the level of response, the better that overall survival. Those with CRs did quite well, while if you added patients who didn't have complete count recovery, didn't do quite as well, and those patients with who did not achieve those level of responses did worse. And then lastly, for the FDA approval components, I wanted to talk about the hedgehog inhibitor Glastigib, which was FDA approved in combination with low-dose cytarabine as well. Again, for those two populations of newly diagnosed AML, patients 75 or older or have comorbidities that they're not candidates for intensive induction therapy. So this is a picture depicting the hedgehog signaling pathway, and typically this is aberrant in AML. So it allows for leukemic stem cell survival and expansion. Overexpression has also been observed in chemotherapy-resistant myeloid leukemic cells. And so what's been seen in preclinical studies, so studies in the lab, is that inhibiting this pathway enhanced sensitivity to chemotherapy. And one way to do that is by targeting the smoothened protein by Glastigib. So The study that's led to the approval was called the BRIGHT study. It was a randomized phase 2 study in newly diagnosed AML and high-risk MDS, ages 55 or older, and they had to be unsuitable for intensive induction therapy as outlined below. And the primary objective was overall survival, but it was a 2-to-1 randomization where 2/3 of the patients received Glastigib 100 milligrams orally daily, plus low-dose cytarabine subcutaneously twice a day versus sub-Q cytarabine twice a day alone. And so looking at complete remission rates, though they're not high, they are definitely improved from what you would see with low-dose cytarabine alone, which was about 2.3% versus 17%. And in looking at overall survival, you can also see that that was improved compared to the low-dose cytarabine alone. But again, like all of these other agents we talked about, are still not considered curative for our AML patients. So next, I'd like to move on to talk about some ongoing research efforts in high-risk AML and MDS that are on the forefront, and we hope may lead to approvals, but are waiting to see the final results of studies. So for TP53 mutated MDS and AML specifically, to talk about that in more detail, TP53 mutations occurs in about 15 to 25% of patients with either MDS or AML. And it occurs in 30 to 40% of therapy-related disease. It's one of the strongest independent predictors of inferior overall survival in MDS, with a much increased risk of AML transformation. So currently how TP53 mutated MDS and AML is approached has been with hypomethylating agents. So it results in a complete remission rate of about 15 to 20% and a 40 to 45% overall response rate, which is similar to what we see in TP53 wild type patients. There's some questions if 10 days of decitabine may improve outcomes compared to 5 days of decitabine or 7 days of azacitidine, but that's really not clear cut quite yet. But even if patients do respond to these hypomethylating agents, their overall survival is inferior and typically is about 6 to 8 months. And when looking at sub-study analysis of the venetoclax hypomethylating agent regimens, for what we know so far, the overall response rate was about 47%. For those patients who responded, the duration was only about 5.6 months and a median overall survival of 7.2 months. So really, adding venetoclax, the question is, does it really seem to make much difference versus HMA alone for these TP53 mutated patients? The other point I want to bring up is we talk about stem cell transplant for high-risk patients. TP53 mutated patients have a very high risk of relapsing after transplant. And so many times we'll want to talk to patients about the high likelihood of that and whether it's something we want to move forward with together or not, because it's quite a lot to go through with the high risk of relapse, or really trying to have clinical trials available for patients to help give us maintenance afterwards to potentially mitigate or decrease that risk of relapse. And so there's a lot of ongoing efforts in that. And so I'm going to talk about some exciting agents, two in particular, for this population of patients with TP53 mutations. So the first is APR-246, or iprenetapot, which I will probably stick to the APR-246, but it's a small molecular reactivator of mutant P53, and it stabilizes the P53 in its functional wild type conformation. And so this reactivation restores apoptotic activity, so tells cells to die, and stops tumor growth. And so there have been different studies that are ongoing. The first was a phase 1b/2 using this agent, which is given IV with azacitidine in TP53 mutated patients with MDS who had not had a hypomethylating agent before, oligoblastic AML, which is defined as AML of blast 20 to 30%, so not very proliferative, or patients with an MDS and myeloproliferative neoplasm overlap. And there were CR rates of about 53%, in particular for MDS, 61%. And 59% of patients achieved a partial or complete cytogenetic response, meaning that their cytogenetic abnormalities complete went back to normal, which is a deeper level of remission. So there was a randomized phase 3 study in TP53 mutated MDS with a combination with this agent with azacitidine versus azacitidine alone, which completed enrollment just in June. And so we're awaiting results. Hopefully some things may be presented later this year. There's also a post-stem cell transplant maintenance study using this combination of azacitidine with APR 246 that has also completed enrollment. That's looking at a primary endpoint of 1 year relapse-free survival, which should be available in mid-2021. There's also an ongoing study in TP53 mutated AML looking at adding venetoclax to azacitidine with APR 246 and comparing outcomes to APR 246 with azacitidine alone. And so I think everyone's very excited about these preliminary responses that we're seeing in these high-risk patients and are very hopeful that there will be exciting final results from the studies from what we've seen so far. Second agent is called magrolimab. It is a first-in-class anti-CD47 antibody that targets the macrophage immune checkpoint. So it's given in combination with azacitidine and was well tolerated and achieved a 64% response rate in unfit AML. And though the median response duration is still, study hasn't been going on for a long time, they haven't seen that there are patients who are, the majority are still responding at about 9.4 months out. There was a 75% complete remission or complete remission with incomplete count recovery rate in the TP53 mutated AML. And also that something we've not really seen, there was some clearance of the TP53 mutational burden in the majority of patients. So seeing a clearance of TP53 is typically not heard of with giving hypomethylating agents alone with studies that we've seen. So again, that leads to a deeper remission and hopefully better outcomes, especially for patients who are able to go on to transplant, or for those who are not, their duration of response is likely to be longer. So there are current ongoing studies in newly diagnosed TP53 mutated AML, and then also just in MDS in general, and not specifically to TP53 mutated disease. The last study that I just wanted to mention is through the Leukemia and Lymphoma Society, is their Beat AML study. And so this is in particular for older AML patients 60 and above. And what it wanted, or the initial design of the study was, can patients wait to get these genetic test results back before starting therapy? Because prior, even when I was initially starting my training, starting to be an attending physician, we really thought patients really need to start therapy as soon as possible because we're going to impact outcomes. Well, now that we have more information and more treatment options, is it safe for some patients to wait and get these results back and then make a decision about their therapy instead of kind of doing a blanket approach to all patients? And so this study essentially has enrolled about 900 patients now across the country in the US, where patients would consent, undergo bone marrow sample, had genomic screening results that would return within a week, and then they would be assigned to a different treatment arm. And what we've seen is that it really is safe for the majority of patients to wait. There's some caveats to that if patients have present with a very high white count or have issues with bleeding, with clotting problems, then we would not say that those patients should wait to start therapy. But for the majority of older patients, it does seem to be safe to wait to get more information to hopefully make a better decision about treatment approaches. And also give patients time to think about really what their goals are and how they want to approach it instead of already being in the middle of therapy and not having had time to wrap their head around what's going on. But these are some sub-studies based off of different AML subtypes that have either fully enrolled or are currently enrolling, and specifically looking at different genomic subgroups and therapies that, at least preclinically or early in clinical development, seem to potentially be helpful. And so what we hope is that by doing this initial upfront approach with looking at new agents, that it may lead to sooner approvals of hopefully good therapies for new AML patients. And this is also an approach that is being looked at to be started for MDS as well. So just to finalize kind of or summarize what I was talking about or trying to convey, is that MDS, though we're making advances, we still have limited treatment options. Most of those are going to be hypomethylating approaches, and allogeneic transplant is really the only potential curative option that we would reserve that for intermediate or higher risk patients. AML is a clinically and molecularly heterogeneous disease, and outcomes are strongly influenced by a patient's age and molecular features. These molecular features can associate with prognosis and also can help to make therapy decisions and serve as molecular targets for treatment. Again, for AML high-risk disease, allogeneic transplant remains the only potential curative treatment option, though with the caveat TP53 mutated, this currently appears to be less effective. There are many ongoing research efforts to determine further treatment options for high-risk MDS and AML, much more than even were just a few years ago. In particular for MDS, we're really excited about all of the interest there, and hopefully we'll improve outcomes. And with these treatment options, we hope that instead of just having improvement in overall survival, hopefully we'll start coming to some curative approaches with new agents. So thank you so much for your time.
Thank you, Dr. Mims. We have a few questions. Our first question, and I'm not sure if you would know the answer, but do you know if there's a difference in cost for the newly approved oral Dacogen versus the intravenous Vidasa?
What I will tell you is that I don't know the exact cost difference. It is expensive, as are all new cancer therapies, unfortunately, but there is a good assistance program to help if there are, for patients who don't have insurance or have high copays, that I know for the patients that we've started treatment so far, that they've been able to get without high cost to them. So I know there's a good drug assistance program in place to help with that currently.
Thank you. This question comes from an MDS patient who is struggling with low platelets. Is there evidence that the use of eltrombopag may help an MDS patient with low platelets?
So I know there's ongoing research looking at agents like eltrombopag for MDS patients. There have been some concerns in the past about potential acceleration to AML with the use of these TPO inhibitors, but I don't know that those are well founded, but I know there's ongoing research efforts to see. And I do know that sometimes people will try them off-label to see. That's not something personally I've done yet, but I think if there are limited options, it's worth having a discussion about.
Thank you. Another question we have is, are there ongoing studies for the TET2 mutations? And if so, where would a patient find those?
So for TET2 specifically, those are thought to be what we would call hypermethylated diseases, and kind of some of their features that we see in the lab. And so there, at least for Beat AML, we have some potential subgroup studies for TET2 or also WT1 or Wilms tumor 1. So I know that there are also some other studies that are hopefully going to start soon, more specifically for TET2 mutated, but there are not a lot of options right this second, but hopefully upcoming.
This question comes from a high-risk MDS patient. They were treated with Vidasa, 7 days of treatment, 4 weeks, every 4 weeks. Then their new plan was to be treated for 5 days every 5 weeks. If this treatment does not work, what would be the next options?
So for high-risk patients, not knowing all the details of the particular case, what I would say is that most of the options are going to be within a clinical trial, and there are definitely clinical trials around the country for higher risk MDS. And I would say I'd be happy to talk or reach out offline to help a little bit more with that question.
Thank you. Are combination therapies helpful for MDS?
So there's a lot of research interest into looking into combination therapy. I think we know giving hypomethylating agents alone, complete remission rates of 20% are, we've got to do better than this. And so with the combination treatment improvements we've seen with AML, I think there's a lot of hope that doing some combination therapies, though maybe with some different targets in MDS, will hopefully lead to improved outcomes. But we're a little bit behind in MDS, but as I mentioned, there's a lot ongoing right now, and so we're hopeful we'll be catching up.
Thank you. Our next question also comes from a high-risk MDS, which secondary MDS, I'm sorry, which resulted from multiple myeloma. Patient is struggling with low hemoglobin counts. Is there a best combination therapy that is currently available for this patient, or that would be recommended?
So for a higher risk, secondary MDS patient, still the treatment approaches for significant cytopenias are typically hypomethylating agents, but sometimes it depends on the patient and the goals, and then some other molecular features. Sometimes we talk about erythropoietin stimulating agents if anemia is a major problem. Also, there's a newer agent for lower risk MDS with ring sideroblast or with an SF3B1 mutation called luspatercept that can specifically help with anemia, but it really would be person dependent if that really would be thought to have some potential benefit or not.
Thank you. Is there a future for oral Vidasa?
So oral Vidasa was just approved for a post-maintenance setting for AML patients after intermediate higher risk who could not go on to transplant. That was just FDA approved just in that setting. And so I know there's a lot of research interest with both the oral decitabine and oral azacitidine, looking at these in place of the IV or subcutaneous treatments and in combination that are ongoing right now, soon to start or have started for clinical trials. So I do think likely the future is oral therapy will likely replace a lot of the IV formulations of these medications. So
Is the oral Vidasa currently being studied for MDS?
So I know there are a lot of different trials that are being, because of the approval that are being put forth to the company for that. And so I do think there will likely be some MDS studies that are going to be looked at as well.
Are there any complementary therapies that are recommended for MDS?
So, I guess meaning complementary, I would take that as, you know, are there any maybe supplements,
Yes.
holistic approaches, that type of thing. And, you know, as of right now, there are not any that have definitive evidence base that they're helpful or not helpful. What I typically tell my patients is, as long as you know, what you're doing doesn't interact with what, if you're taking a chemotherapy or another agent and it's going to offset the effects of that, there's still a lot to learn in medicine. And so I think there are a lot of there definitely is room for that, and I think it can definitely be a benefit. But it's just important to have a discussion about what those are, you know, with your treating physician.
And this question comes from a patient who recently started Inqovi, and they've been having what they feel is some serious side effects. They're not feeling well. Is there a time period that patients should wait to see if those symptoms subside? And when would a patient likely see benefit from the treatment? When should a patient expect to see some type of response?
So it's similar to what you would expect with decitabine. So the responses should be after about 3 to 4 months of treatment. What I would say is, depending on what the side effects are, it would be how to approach it. And you know, there are dose reductions that are recommended in the label, and so that might be an appropriate thing to do. You know, we do all of these medications, they're weight and height based, but they're not, the metabolism between different patients are different. And so it may be that potentially you need to go down on the dose for it to be tolerable, but it could still be effective. So I think it would really just depend on what kind of side effects you're experiencing as to how to best approach that.
Thank you. For a patient who is currently using Vidasa and maybe is not seeing an optimal response, should they consider switching to Inqovi, the new oral medication?
So what I would say is that there's not a lot of evidence showing that if you switch from one hypomethylating agent like decitabine or azacitidine from another, if one's not working, that the other one will be effective. Typically it's not, but I think if there are limited options, I don't think it's unreasonable to try and to see. So.
Thank you. If a patient is currently using Dacogen and receiving you know, that by injection or IV, how would they switch over to the oral formulation?
So it's definitely not recommended you switch within a cycle. So if you're doing a cycle, you should complete that cycle with the method you're doing. But for subsequent cycle, you could switch over. It would just be having a conversation with your treating team, and you know, and essentially they would need to send in a prescription and get approval. But there wouldn't be an issue as far as if you wanted to switch over. Instead of doing the IV, because again, they seem to be similar in the absorption and kind of the blood levels of the drug that are seen.
Well, thank you so much, Dr. Mims, for sharing your time and your expertise with all of us today. And if you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have additional questions, you can send it to us at any time and by 3 ways. Send us an email at help@aamds.org. Call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to support you and your family as we have done for the past 36 years. This concludes today's program. Thank you again, Dr. Mims.
Thank you all.